I summarized the chapter in the Lawrence, and I quoted some slides from Dr. Hani Najm talks about the adult congenital, but there is no disclosure. So the outlines as following. So, we'll go through introduction about adult congenital heart disease. We'll talk about ASD, all from surgical point of view, piston anomalies, Fontana revision, right ventricular outflow tract reconstruction, and left ventricular as well, arrhythmia surgeries, hyper procedures, coarctation of aorta, and interventional device. And last but not the least is improve outcome of congenital towards the treat of adult. And the second lecture, I will continue with the guidelines management, the 2008 in adult congenital. So as introduction, so over the past 2 decades, the spectrum of complexity of adult congenital have been evolved more with the cases and became primary repairs as a surgical intervention. Those cases was include the coarctation of aorta, patient with ductus arteriosus, septal defects, tetralogy of Fallot. Reoperation on survivors of this complex was in multi-stage as palliations. Secondly, the aim was to reduce the cumulative trauma of care of those patients, so that it will expand the lifetime of adulthood. The treatment option selection was the least traumatic. So basically was for, as we will see, for each case, we'll start with the least invasive. First of all, PCI, then or interventional cardiology, then to minimal invasive, then the surgical, if possible. And for example, like the cases of ASD, as I will mention later on, first of all, if possible, it will be device closure, the first line of treatment. If not, then the surgical. So patients with complex lesions often had dense medical histories since they are child, or even most of them with congenital anomalies. So the history and the medical history is the main component of those patients. The patient's education, the family, what is the expect transition of adulthood. So mainly those patients will become with a lot of surgical history, a lot of operations, and most of them, they will come as a redo. So this picture shows actually that the kind of system that been used in US, so you can follow up the patients as an system-wise of management. So that will be in the information system that will be uploaded in the system, and wherever the patients go to any center, that will be as a follow-up. So that mainly it was the EMR, which is the electronic medical record, and personal health record also. So congenital heart disease, most common. So that we can talk about on adult congenital. I'm gonna a little bit talk about congenital heart disease. So the commonest type of birth defects is the congenital heart disease. 1% of babies are with congenital heart disease. 40,000 births per year in US. 25% of those have critical life-threatening defects. 10,000 babies born with the critical congenital heart disease annually. So in the lifetime before 1950s, most of them died during infancy, and the survivor had really severe limitations. Between 1950s and 80s, rapid improvement happened toward the surgical technique. So many of them survived toward adulthood. In the modern era, death during childhood is rare, even with the most complex forms of congenital heart disease. So challenges of adult congenital heart disease are growing population, young specialty, most palliative surgeries, most of them. So the patient, even if you do, they will come back again with another complication. Never seen sequelae, sometimes shunts left, right, then upgraded to something else. Uh, Large variety of defects and spectrum of evolving technique. So that's why we had some novel technique like the one that Dr. Najm talked about, the septation of ventricles. So each surgeon can input his own technique or his new technique. Combination of treated and untreated congenital heart disease with acquired heart disease. So they are very risky patients, multi-organ involvement, complex of lesion include peripheral vascular disease, ventricular dysfunction, volume and pressure overload, cyanosis, arrhythmias, the most worst thing and the most common complication among them, adult comorbidities, DM, hypertension, renal and COPDs or pulmonary disease. So the technical consideration of adult congenital should be the previous operation, as I mentioned, throughout some system or follow-up or good history taking, myocardial preservation, since they are young patients and they have lifetime to spend. Cardiopulmonary bypass technique and collaterals among the redos that will be very challengeable, vascular access as well. So during the sternotomy, re-sternotomy for those kind of patients, femoral cannulation is often difficult because of stenotic or occluded femoral vessels, because of recurrent access to those vessels or to the femoral, very often angios that happen. So it will be very difficult. Key risk factors for adult congenital as reoperation will be included re-sternal ventricular to pulmonary artery conduit that will be clearly embedded to the sternum. Sometimes pulmonary hypertension, RV enlargement, prior sternal infection, aneurysms of right or left ventricle outflow, pectus excavatum, or aortopulmonary shunts. Also, patients with multiple risk factors may be placed on bypass to decompress the right ventricle prior to the sternal division. So to reduce adhesion formation and decrease risk of to prevent the cardiac dissection by covering the heart, some surgeons use the saline salt gauze throughout each operation, so that we can prevent the adhesions. Use of anti-adhesions material to decrease the retrosternal adhesions. In some centers, they expanded the polyethylene, the BTFE, is routinely placed behind the sternum prior to the closure. So the ASD, atrial septal defects, how to approach in adult congenital. So multiple incisional approach that can be described. As I mentioned, that we can go first of all by device, then minimal invasive, or the median sternotomy. A consideration that we have has been taken throughout the ASD. Our venous cannulation strategy for ASD is bicable and right atrial appendage into the superior vena cava and down to the inferior vena cava, vena caval junction. And in smaller defects, sometimes that has been closed eventually, or primarily, I mean. Now rarely referred for surgery as well, the smaller defects. Having said that, for sinus venous defect, we place the right-angled cannula in the innominate vein to enable exposure of or partial anomalous of partial anomalous pulmonary vein entering the superior vena cava. The atrial incision is made laterally to avoid the sinus node and is extended superiorly at the point above the entrance. Uh, Maybe I can explore here in the picture. So we can see here the ASD, and here the right pulmonary vein, and here is the SVC. The IVC will be down here. So, and here we can see the pericardial patch, that the closure of the ASD. Here the SVC right atrium patch along the right atrium, and here is the SVC. So for the primum ASD, the cleft mitral valve is routinely repaired with the fine running polyproline sutures in contact between the leaflet segment. The patient component of valves should be repaired. The onset of cleaflet regurgitation is commonly occur. Patient risk for mitral stenosis, particularly those with a single papillary muscle. So as a result, for these repairs are excellent, and patients can get along with their ages to advanced age. So for Episton's anomaly, the presence of an untethered and well-developed anterior tricuspid valve leaflets increase the chance of successful repair, and have used the cone technique in an adult patient. I don't have picture for that, but just to explain the cone technique in those patients, the repair requires dissection of the anterior and posterior tricuspid valve leaflets, because of most of patients with piston anomalies, mainly in the tricuspid valve, as we know. So from there, a right ventricle attachment, the free edges of the anterior leaflet then rotated clockwise and sutured to the septal leaflets border. This is mainly the cone, like a cone shape technique. Next, we're gonna talk about the Fontan revision. So for the Fontan patients, may present with arrhythmia and complication related to the systemic ventricular failure, protein losing enteropathy, systemic venous pathway obstruction, semilunar or arterioventricular valve dysfunction. Initial evaluations must be focused in ensuring completely unobstructed vascular pathway to the lungs. Right atrial enlargement can easily found, resulting in stagnant flow, right pulmonary vein compression, and arrhythmia. So involving of electrophysiologists to ensure the effective interruption or ablation of all reentrant pathways is important, since the main two worst complication with those patients, the arrhythmia and the protein losing enteropathy. So now recommended routine placement of dual chamber anticardial pacemaker with the bipolar steroid eloting leads for these patients. And usually actually those patients done as an hyper procedure. So the electrophysiologist part and the surgery part at the same time. So for the right ventricular outflow tract obstruction, after previous repair of tetralogy follow, double outlet right ventricle, pulmonary atresia, and truncus arteriosus, along with the atrial switch procedure, are increasingly common with those patients. So returning of pulmonary insufficiency or stenosis, resulting in right ventricular dysfunction, exercise intolerance, arrhythmias, and can reach up to sudden death. So as a preoperative evaluation, echo, MRI, and angio is important, used to identify to concomitant lesion, particularly the patent foramen ova, coronary anatomy as well, and RV dimensions with the function. These repairs may be performed without ischemic arrest. Provocative preoperative testing of papal test with the Valsalva is negative. So if the patent foramen oval is closed and the Valsalva is negative, that's a negative test. So here in the pictures, we can see that the right ventricular outflow reconstruction with the bovine jugular vein graft. And here we can see the pulmonary homograft as well, closing and here the RVOT is with the running suture technique and an onlay patch. The onlay patch above the closure. So next is the LVOT, or the left ventricular outflow tract reconstruction. Those patients came with the Ross operation, is often used in pediatric patients with the complex type, combined with the valvular and subvalvular lesions. They should avoid anticoagulation and maintain with some growth potential. The follow-up of RVOT or LVOT after Ross operation can show up to 4% of patients will require conduit replacement with right ventricular dysfunction up to at 10 years, aneurysmal dilatation of new aortic root after Ross operation is related to use of root technique, and may be seen up to 11% of patients at 7 years old. The cono-aortic ventriculoplasty is used to treat the complex LVOT. So in review research, they found 53 patients operated in form of 1980s to 2004 with an average of 19 years old. Reported risk factor over mortality included the hazardous ratio of 2.2, which with the p-value of 0.04. The cumulative probability of aortic valve reoperation was 19 at 5 years old, and 19% at 5 years old, and 39% at 10 years old, occurring in 15 patients with median of 3.8 years. So the pulmonary regurgitation was detected in 6 patients. Pulmonary valve replacement was performed in 3, which equals 6%. So arrhythmia surgery, in adult congenital patient at risk of wide array of conduction delay, as well as in atrial and ventricular tachyarrhythmia, pacemaker and defibrillator insertion, most common in adult congenital cases, lead extractions also, generator changing, and frequently complicated because of infections or stenosis or occlusion of veins. Epicardial leads placement often necessary in single ventricle patients who have limited or no venous access to the endocardium. So the common indication for the lead removal, as I mentioned, that infection or malfunctioning, pocket infection, skin erosions, endocarditis sometimes, septicemia, vena cava thrombosis, and painful leads. So the lead extraction technology is evolving and can be safely managed with the hybrid effort. The surgeon, along with the AP, with the electrophysiologist, working together number of lead removal catheter are available should be in the hybrid room. To excise the embed leads, surgical support is necessary in event of cardiac perforation as a complication. Supraventricular or ventricular arrhythmias are major cause of morbidity and mortality in adult congenital cases, as I mentioned before. For patients with atrial fibrillation or flutter undergoing open heart repair, right-sided maze procedure can be performed with the expectation of 93% freedom from arrhythmia, and improvement is in functional class. So speaking of which, the hybrid procedure, this is a picture showing that the catheter, the angiocatheter in a hybrid procedure, along with the mineostonotomy in the lower side of the sternum. So this is the main concept of the hybrid procedure, the angio along with the surgeon at the same time. So routinely deploy of aortic and pulmonary artery stent in the operating room using the direct vision, the video-assisted cardioscopy, and the angiography. Pulmonary artery stent may be positioned or more proximally to avoid the damage of small distal branches at the time of reoperation. Aortic artery stent positioning can be optimized to reduce the distance down to the distal arch, as the surgeon must dissect the reoperation. It's required to open the stent or cannot reach even the adult side. Next is the coarctation of aorta. Primary and recurrent coarctation of aorta in adult patients is increasingly managed by PCI with the Pallon dilatation or a stent. Providing the surgical backup, as we mentioned in hybrid room, or even device migration, dissection, rupture that commonly happen along with the angio. So that can be managed by surgery. When transcatheter therapy is not feasible, we proceed with the surgical repair of adult with the coarctation of aorta or arch obstruction. So there is 3 general techniques can be used, including the coarctation of aorta end-to-end anastomosis, or onlay patch, enlargement with the tissue, or prosthetic patch, along with the coarctation, synthetic tube interposition. Aortic mobility limited in adult patients, so the tension-free repair must be required interposition of the graft. We use subcutaneous local anesthetic infusion catheter and liposomal ibuprofen to control the postoperative vein, as in dissection cases. We anticipate the labile blood pressure responses in patients with long-standing hypertension, and this is actually the main post-operative complication. The hypertension is really more common in those patients. So can be respond with the sodium nitroprusside. Mortality for this procedure is rare, and follow-up up to 75% patients will be normotensive without medication. So interventional device management will be, the cardiac surgeon will increasingly encounter the adult congenital heart disease patient with intravascular devices in aorta, pulmonary arteries, atrial and ventricular septic defects, along with the transcatheter stenting valve. So the reoperation early after stent implantation, the cutoff point is the 3-month period. So if it's 3 months or less, it may be possible of completely remove of the stent easily with the scissor, and the stent can be collapsed inward and peeled out. After 3 months, the complication of the injury is more liable to those patients. Incorporated with the vessel wall, making removal is really difficult and traumatic. So the stent will have to spread open like a hot dog pan, يعني زي سندوتش الهوت dog. So if we explain in this picture, for example, this is the stent. We can see here the stent. This is the stent. So you will just open, and it will be flapped. The two septum will be flapped each way, and it will be peeled out with the scissor and with the forceps or something to take it out. That requires every link to cut the distal end, and to avoid having persistent complete ring in metal in the vessel wall, along with the vessel wall. So last topic in the first lecture is how much is improvement that happen as an outcome of congenital heart disease along with the adult congenital heart surgery treatment. So in review of 72 US centers, along with 2,800 operations performed per year, ranging from 0 to 230. The median was 28 per each program, 2 surgeons at each one have averaging of 20 cases per year. So each individual program they have found the congenital heart surgery is 1.87% mortality. Along compared with the adult acquired adult heart disease surgeon, 4.84% mortality. So the p-value was less than 0.0001. So that will tell us that the patients with the congenital heart disease are living longer, along with the congenital heart disease surgery. So the arrhythmia remains the primary contributing cause of death, as I mentioned in the beginning, with the cyanotic lesions especially. MI now is the leading contributing cause of adult, along with the non-cyanotic congenital heart disease. The consistent with the survival and increasing impact of acquired heart disease. So this is for the first part, the first lecture. Any question? Or should we
yeah, Guru, are you with us?
Yes, yes.
I'm here.
Okay. I'd like to introduce the group to Dr. Grushin Veltman. He is a world expert in adult congenital heart disease, and he's a staff cardiologist in King Faisal Specialist Hospital. I just invited him to join us in the meeting. He also arranged for a bi-weekly club meeting for any of you who are interested in adult congenital diseases. Guru, this is the group of cardiac surgeons in training across the kingdom. There are about 28 participants with us. I'd like to hear your comments or advice for the group about the lecture, what you just heard.
Yeah. Well, thank you so much, Farid, for the kind introduction. And it's really great to meet all of you, even if it's just virtually. And I would really like to extend the invitation, as Dr. Farid says, to our meetings, which will hopefully be continuing, as we sort of get used to the whole living with COVID-19. From the adult congenital surgical standpoint, so firstly, thank you so much for providing such a good all-around insight into it from the surgical point of view. I think you've given a really good overview of a very broad range of topics excuse me, just a few things that stood out for me is, the reoperations that we see in adult congenital patients sometimes is quite scary in a sense. And Dr. Fried and I have spoken about this also in the past. Sometimes you get folk coming back for 6, 7, 8 operations. And those patients, I'm pretty sure the experience for you from a surgical point of view is tough. Another big group that and that's the Epsteins, which you spoke about briefly. Now, I've not personally seen many here as yet that have operations during adult life, but in my previous practice, I've seen quite a few actually. And I have been surprised at how well many of them do following the cone operation. And many centers are doing those operations well into the 60s and 70s, and sometimes even older. And I know in the Mayo Clinic, certainly that that happens, that they tackle older patients and they use a Glen in association with, with the cone repair. And that's, and there's many other comments, of course, still, but I think the issue also of experience and having one surgeon, 1 or 2 surgeons who do a lot of adult congenital, like the paper you showed from Brian Cogan when you were still in Atlanta, I think there's a lot to be said for a surgeon who's keen and enthusiastic about adult congenital work, because it's not always very rewarding, like, pediatric practice or, doing an arterial switch. It's not quite, it's not so exciting to do a 10th redo pulmonary valve compared to an arterial switch. But, still at the same time, the patients are very, very grateful, and so are the cardiologists, the adult congenital cardiologists, by the way. So I would greatly encourage those amongst you who feel a sort of calling to this to respond. And sorry about the long response, Fareed. It wasn't, I could have been shorter. I could have done better.
Well, thank you very much for those comments. Any questions from the group? By the way, the presenter is Dr. Amjad Barnawi. He's a second-year cardiac surgery resident.
Okay, thank you, Dr. Amjad. That was a nice job you did.
From the Eastern province.
Okay.
Back to you, Murtada.
Dr. Amjad?
Yes?
Can you put the slide again, the slide before the hybrid procedure?
Okay.
The slide with May's procedure.
Yes. This one?
Yeah. Here you mentioned it's just to do the maze on the right side. It makes sense to do it for atrial fibrillation, atrial flutter, but why we have to do only the right side for atrial fibrillation? We know the most source of atrial fibrillation is around the pulmonary vein, which is on the left side. So what's the idea, Dr. Fareed, or to do only the right side?
Of course, as you said, when we are facing this challenge of arrhythmias along with the structural heart disease, we try to do the complete maze. But remember, those are redo patients. They may be the 5th or the 6th redo, very difficult fibrosis and adhesions involving most of the service. So it's very difficult to reach those areas. And many times, even if we reach them, we cannot go with the full thickness procedure from here and there. So what we try to do If you cannot reach the, for example, the pulmonary veins with the clamp, radio frequency clamps, because of the adhesions, we just go around the pulmonary veins with the cautery or with the radio frequency or even with the cryo probe. So it's the matter of the risk that involve the dissection of the left side rather than the inability or the unwilling part of the surgeon to do it. So if you have such a huge risk that you're going to be cutting and you will not be able to fix it afterward, it becomes an issue. But you already have exposed the right side, so you can do it there. Yes, you will have some failure rate, but it may help those patients, some patients.
Yeah, but according to this slides, it's the freedom, it's around 93%. So even if we have access to the left side, we can sacrifice 7% of patient and get the success of only doing the right side. So in these patients, anything extra or any source of the atrial fibrillation comparing to the other type?
I would say no. It's probably this all the same area we still worry about, and this rate has been declining as you follow up those patients more. So yes, the initial reports for the first year, they say 80 to 90% success rate, but then if you dig around for it, if you do less procedure, you have higher recurrence rate. I would say as a surgeon, you are in the middle of the midst of things there, and you have to choose how much risk you can take. If you can reach that area safely, yes. But if you face any trouble, just give it the best you can, which is usually the area that we already have exposed. Guru, do you have a comment on that?
Yeah, Farid, I agree with all of what you and the previous speaker said. I think by and large, it's a better approach to try and get both the left and right atria if you can. But also we do know that, a lot of congenital heart disease, the ASDs, sinus venosus ASDs, tetralogies, a lot of it involves first and foremost the right atrium in terms of atrial arrhythmia. And so therefore the idea initially, and I remember the days when we did this approach actually, that was all driven by the belief that the atriopathy was predominantly in the right atrium. I think now with increasing understanding though, I think it's become very clear that the atriopathy is rarely isolated to the right atrium. And therefore it makes perfect sense to do both preferentially. But there's also another issue, which is that much of the atrial fibrillation in congenital heart disease may be driven by right-sided atrial tachycardia starting off like that, or right-sided atrial ectopics or something, and that induces tachycardia. So that's why there is some success rate with just doing the right atrium. But on balance, though, I still think I agree with both of you, Farid and the previous speaker, that a biatrial maze, when possible, and it doesn't extend the procedure too long, is the best way forward.
And if we have to do the bilateral maze, still we will get the left appendage in those patients.
For a cardiologist, that is like music to our ears, by the way, because it means that we don't subsequently have to send the patient for left atrial appendage percutaneous closure. And, a lot of the stroke risk comes from the appendage. So, the classic Cox maze procedure very much included that. So, and I would just caution, many surgeons have told me in the past that when they try and exclude the left atrial appendage, sometimes they don't completely do it, and therefore you can get clot accumulation in whatever residual connection there is.
Thank you.
And Hussein, this part may be an easy part, because even if you don't expose it from outside because of the adhesions and the worry about the course of the phrenic nerve or the inability to expose the appendage, you can do it from inside by just direct suture. And we usually use continuous protein suture with some interrupted sutures to avoid reopening. Yes, it may reopen, and there is reported instance of that. Even if the one we ligate from outside, it has shown that it may have recanalization rate somewhere around 5 to 10%.
Thank you.
Okay, so thank you very much for these comments. Now I think we will finish our last presentation, which is the American Heart Association guidelines for adult heart disease, for adult congenital heart disease.
I'm